And spectroscopy did show significantly elevated choline, and choline to Na as well as choline to creatinine ratios were more even after normalizing it. We could also see there was a lactate peak because of the predominant necrotic central part seen in this. This patient underwent a follow-up MR just 1 month later, and which showed a significant increases in the size of the lesion, confirming it to be a recurrent tumor. Therefore, all three modalities in this case did help us in saying that this was a recurrent tumor rather than as a treatment-induced changes. Another 27-year-old male patient operated for a left frontal astrocytoma, baseline post-therapy MR, again showing just a post-operative cavity, no significant lesion seen, but a follow-up MR, surveillance MR, in fact done 5 years later, did show evidence of a new necrotic as well as solid enhancing lesion appearing in close vicinity to the site of the original tumor. The diffusion weighted images did show significant restricted diffusion on the DWI images as well as seen better on this ADC map. And the RCBV maps clearly showed that there was significant elevation of RCBV in this particular solid, at least the solid part of the tumor. The metabolite ratios did show a significantly elevated choline and depressed Na, therefore significant choline to Na and choline to creatinine ratios. And the patient underwent operation. Histopathology was a recurrent glioblastoma multiforme. A 57-year-old male patient who was operated for a left frontal GBM. This was the post-operative cavity, again a post-treatment baseline MR, showed only a small focal area of nodular enhancement just adjacent to the site of the original lesion. This was followed up serially over 2 years, did not show any significant change in size. However, a follow-up MR 3 years later suddenly showed that there was a large, predominantly necrotic, irregular enhancing lesion occurring in the vicinity of this original tumor site. If we see other images also, we can see there is a conventional imaging clue that this is a classical Swiss cheese type pattern of contrast enhancement rather than a slightly solid pattern of enhancement. Maybe treatment-induced changes. We took the help of this diffusion. There was almost no restriction of diffusion, only for an exception of a small spotty foci of a restriction of diffusion, also seen on this ADC map. Again, perfusion maps did not show any significant elevation of perfusion. Even the ROI, they gave the values which were much less than the threshold described in literature. And overall, the metabolites were all decreased with a significant lactate peak. So this was followed up 6 months later, and 6 months later there is a significant decrease in the size of the lesion. Therefore, this patient had a treatment-induced changes. Last example, a 27-year-old male had operated for a right frontal GBM. It was asymptomatic. This was a baseline post-treatment MR. Just few signal changes on flare on the right paraventricular region, no enhancing lesion. However, a follow-up MR 3 years later did show a similar to a last case, a large necrotic, irregular marginated enhancing lesion with mass effect as well as edema. Diffusion again did not show any significant restriction of diffusion except for a small spotty foci. Again, better seen on this ADC map, correlated with ADC map. And the RCBV was also not elevated. If you see the values also, these are also equal, in fact, less than 1. This is 0.5. The normalized ratios were also pretty less. And this, on a follow-up MR, 4 months later, there was a complete disappearance of this lesion. Therefore, it was again treatment-induced necrosis. If you see the initial MR, this is quite worrisome. But just 4 months later, there is almost complete resolution. In fact, on no treatment at all. These are treatment-induced changes. So at our institution, we actually did a study which we presented this year at ASNR also. The total 36 patients in which 24 were tumor recurrent and 12 were treatment-induced changes. We did find some conventional MR imaging clues in terms of the best clue was an enhancing solid component. If seen either in isolation or together with other components of spread across midline, corpus callosum involvement and well-defined margins, to a great extent could predict a diagnosis of recurrent tumor over treatment-induced changes. As far as diffusion was concerned, more than 85% of the tumors did show a visible restriction of diffusion on the traced DWI images. Most of them actually showed homogeneous pattern of restriction of diffusion, as I almost shown in my first case. Few of them did show spotty foci of restriction of diffusion. In contrast, treatment-induced changes, none of them actually showed homogeneous pattern of restriction of diffusion. On 25% of them did show some restriction, but it was only patchy foci of restriction of diffusion. So this was quite helpful in differentiating between the two. The ADC ratios, the normalized ADC ratios were also calculated. We found it in the range of 1.2 to 1.3 in the tumor recurrent group and around 1.6 in the treatment-induced changes group. However, in our study, we did not find it to be statistically significant. As regarding perfusion MRI, we found it to the best and the most robust modality, advanced MR modality in differentiating between the two groups. We actually did, we could put in thresholds. We gave a thresholds of minimal to maximal of 1.5 to 1.7 normalized RCBV ratios, above which actually we could say with very high specificity and sensitivity that it is likely to be tumor, and less than that we could see that it is most likely to be treatment induced changes. This is in deviation from the 2.6 which has been earlier said in the literature, and all of our ratios were statistically significant in terms of RCBV maps at least. Spectroscopy, we did found that the normalized choline to Na ratios were significantly elevated in the range of around 5 in the tumor group and around 2 in the treatment induced changes group, as well as normalized choline to creatinine ratios were in the range of 2.7 in the recurrent group and much less, around 1.3 in the treatment induced changes group. However, none of them was statistically significant for differentiation between the two, at least in our study, so we did not put much reliability on the spectroscopy. It does add to our confidence, but you just cannot take it as an isolation to comment between the two. So in conclusion, all three modalities, specifically with contrast enhance, gives you the best results. Perfusion is definitely the best, as well as visual inspection on diffusion weighted images. And you can actually differentiate most of the patients based on advanced MR imaging techniques. I've already told you perfusion is the most suitable we found, and MR spectroscopy not so much reliable as we found out in our experience. With this, I thank you all for